Yeah, please.
Good morning, everyone. I'm Dr. Amogh Zawar, and I'll be speaking on effect of in-situ fusion in lumbar spondylolisthesis on clinical outcomes and spino-pelvic sagittal balancing. It's a case series of about 138 patients. So as we all know, the treatment of listhesis has been a matter of interest purely because the etiology of this disease is multifactorial. And the basic two surgical treatments which we all know is in-situ fusion, number A, and B, reduction in fusion of the involved segment. It has been long demonstrated back that the spino-pelvic morphology is abnormal in cases of listhesis and is associated with abnormal orientation as well as disturbed global sagittal balancing. So it is this global deformity that makes the surgical management so complex and challenging. So we divided our patients into different categories using these three grading systems: the Mayarding's classification, which was the most commonly used, Wilts, Newman, McNutt classification, and for the radiological outcomes, we used these three parameters. One was the sacral slope, the pelvic tilt, and the pelvic incidence. The aims and objectives of our study was to assess clinical and functional outcomes of in-situ fusion and also to evaluate the radiological changes in surgically treated cases of listhesis. So it was a prospective study conducted for about 1.5 years at Sancheti Hospital, Pune. We included 138 patients. And the inclusion criteria for this was age group between 20 to 80 years, and the types included degenerative, dysplastic, and ischemic spondylolisthesis. We excluded traumatic and pathological listhesis cases and the cases which were treated conservatively. A detailed history and clinical examination for these patients were done, and we assessed functional outcomes with respect to VAS score, the ODI score, and the SF36 score. The X-rays and MRIs were done. Out of the 138 patients, about 80% belong to the degenerative group and about 20% belong to the ischemic group. They were followed up at 6 months and at 1 year. The procedure, the prone position, and just to specify, we did a transforaminal interbody fusion by putting, and the bone graft was packed into the anterior disc space and in the PEEK cage before the insertion. The post-op protocol included high dependency unit admission for about 24 hours and antibiotics and DVT prophylaxis. The patient was started with in-bed exercises within the first day and was made to walk with a walker support on the second day. Now the results, as we can see on the X-ray parameters, the mean pelvic tilt and the mean pelvic incidence showed statistically significant improvement in the values, whereas the mean sacral slope showed improvement which was not statistically significant. And the functional outcomes, as you can see, the median VAS score, the median ODI score, and the mean SF36 score, all of three showed statistically significant improvement. Coming to the complications, 9 of our patients, which contributed 7% of the total number of cases, showed pseudoarthrosis on X-rays, but they did not seek any treatment. 4 patients developed transient neurodeficit post-operatively, but which was recovered at the end of 1 year, and 4 patients had superficial infection which were aptly treated with IV antibiotics. 12 patients had dural tear intraoperatively and it was addressed. Coming to the cases, a 50-year-old gentleman with grade 1 listhesis at L4-5 was operated with decompression and L4-5 TLIF. Clinically, he had good forward bending, extension, and lateral flexions. Another 61-year-old gentleman with grade 1 degenerative listhesis at L4-5 was treated with decompression, instrumented stabilization, and TLIF at L4-5. He had good sitting posture. Another 48-year-old lady with grade 1 degenerative changes were operated with the same. So for the discussion part, the Lamartina et al. Also prospectively analyzed the degenerative listhesis cases, comparing both with or without reduction, and concluded that open PLIF and pedicle screw fixation could achieve an effective and satisfactory outcome regardless of reduction or not. Also, Sasso et al. Reported the results of partial reduction of the slip angle only and concluded that complete anatomical reduction of slips is not essential and that partial kyphosis correction followed by fusion from L4 to S1 resulted in satisfactory scores. Of course, there were some limitations to our study. It was just 1 year follow-up study, and we hope that improved scores and longer follow-up might increase the significance of this study. Also, a randomized comparative study between the two modalities of surgical treatment by a single surgeon at a single center is needed to assess the outcome better. So to conclude, statistically significant clinical results were achieved because the slip was stabilized and the neural elements decompressed. In-situ fusion have given equally comparable results to that of reduction in fusion with respect to functional scores like ODI and radiological parameters of spino-pelvic sagittal balancing. The disadvantage of in-situ, however, is pseudoarthrosis, but it is not shown to affect the functional outcomes and the quality of life scores. Thank you so much.
Thank you, Amogh. Any questions from the audience?
How did you manage the cases which had pseudoarthrosis?
So the pseudoarthrosis cases, we saw that on X-rays only on the follow-ups. Thankfully, they did not have any chief complaints as such. So with a longer follow-up, if the chief complaints do not develop, we'll just keep a close watch on them. That's it.
Sorry. Amogh, well spoken. Regarding the complications of transient neurodeficit that you have,
Right.
was it a continuation of the pre-op neurodeficit? Was it similar in the root value, or was it something completely unrelated?
No, sir. The pre-operatively, the grade of neurodeficit persisted post-operatively, but that improved at 1 year follow-up.
Okay. So then that's no fault of the surgeon then?
No, sir.
Absolutely. Thank you.
Thank you so much.
Thank you. May I now